Okay, good morning, everyone. We're going to begin. My name is Beth Ann Turnavin. I'm the supervisor of the counseling program and employee assistance program here at Family Services Windsor-Essex. And I would like to welcome you all this morning, those of you who have joined before and new joiners today. On behalf of Jennifer White and all of us here at Family Services Windsor-Essex, we welcome you to our series of seminars, Coffee with Colleagues. Our second seminar is about the principles of General Psychiatric Management for borderline personality disorder. Please note, everyone, that we are recording the session. The slides will not be available afterwards, so you will be able to access the recording subsequently, and we will advise you about that. We want to acknowledge that we are joining you from the traditional territory of the Three Fires Confederacy of First Nations, comprised of the Ojibwe, the Ottawa, and the Potawatomi. We invite you to submit your questions during the training through the chat function, and myself and my colleague Allison Prier will manage the chat questions after the presentations. It is my pleasure now to introduce Dr. Mohsen Beg. Dr. Beg is a clinical psychologist and licensed in the province of Ontario. He's currently working at both as the executive director of the Student Counseling and Wellness Center at the University of Windsor, as well as in his private practice at Paragon Psychology. He earned his undergraduate degree in psychology from the University of Toronto and completed his master's degree and PhD in clinical psychology from the University of Windsor. Dr. Beg has trained and worked in a variety of clinical settings and is a colleague of our two speakers today. And over to you, Dr. Beg.
Thank you very much. It's a pleasure to be here, and it's a pleasure to be introducing my two colleagues and friends, both Dr. Harrington and Dr. Yeryomenko. I will start with Dr. Yeryomenko. He is a clinical psychologist in a generalist private practice working with adult clients. He graduated from the University of Windsor in 2017 and completed his residency at the Student Wellness Counseling Center at Memorial University of Newfoundland, where he developed a strong interest in the step care model of delivery of mental health services. He was later hired to consult on implementation of stepped care at the University of Windsor, where he worked for several years before leaving and entering private practice. Dr. Yeryomenko is also interested in the delivery of psychological services in primary care settings, as well as in interprofessional training and education. He holds the rank of blue belt in Brazilian Jiu-Jitsu. He likes drawing with charcoal and hangs out a lot with his pug named Chuck. Our other esteemed speaker today and my colleague, Dr. Shawn Harrington, is a clinical psychologist licensed with the College of Psychologists Ontario. He completed his PhD and MA in adult clinical psychology at the University of Windsor. Dr. Harrington is licensed in the areas of adult and adolescent clinical psychology and adult rehabilitation psychology. Dr. Harrington completed a pre-doctoral residency at the Dr. Everett Chalmers Regional Hospital and Stan Cassidy Rehabilitation Center in Fredericton, New Brunswick in 2015-2016, where he worked in inpatient, outpatient rehabilitation psychology, inpatient health psychology, and inpatient psychiatry. His current practice in psychotherapy is grounded in emotion and psychotherapy research. Dr. Harrington's clinical approach is integrative in nature and is informed by emotion-focused therapy, cognitive behavioral therapy, motivational interviewing, and mindfulness. He is particularly passionate about working with local emergency service workers. It's my pleasure to be here and listen to both of them. Thank you.
Thanks for the nice introduction, Dr. Beg.
That'll be $20 later.
Thank you, Mohsen. So I guess over to us, right? Let's see. Please let me know if you can't hear us, right? Otherwise, I guess, yeah, we're gonna talk about. We'll try to make sure we're on time. It's a lot of ground to cover, so maybe we'll go a little bit over, but hopefully not too much. So the story started actually in 2013 with Dr. John Gunderson, who you can see here on the slides, coming to University of Windsor. And both Shawn and me were invited by our supervisor at the time, Dr. Pasquale Leone, to come, see the psychiatrist doing a talk on this approach for borderline, because everybody heard about dialectical behavior therapy, and for many years I thought that's the only game in town. There's other specialist treatments such as mentalization-based psychotherapy, or transference-focused psychotherapy, but GPM was a little bit different. And what I didn't know at the time is Dr. Gunderson, who did a free 4-hour workshop for anybody who was willing to attend, was actually the person who created the diagnosis back in the day, and he's been working tirelessly throughout his life to kind of improve access to care for these individuals. And sadly, he passed a couple of years back from cancer, I believe. So GPM, called either good or general psychiatric management, I think right now it goes by general, is a sort of case management approach that's suitable for any mental health provider, including family physicians. You don't actually need to be a psychiatrist to do it, which kind of like, it's there in the name, right? It's flexibly multimodal, and clients, you see them about once a week with very little contact in between sessions. The focus, I guess, of this treatment is life outside of treatment, right? The goal of GPM is to help clients build a life worth living, which is a little bit different than the focus on symptom reduction and many kind of other approaches. And the general gist of it is, once you get individuals kind of more interested in their life, more interested in kind of like having steady, gainful employment that they enjoy, or going to school and building social circles that aren't these exclusive romantic relationships, you set them up for kind of like a course of improvement in life. Psychoeducation is emphasized throughout this approach, and progress through treatment determines its duration and intensity. We're going to talk about that shortly. But first, some trivia. Over to you, Shawn.
I bet you didn't think you'd have this much fun this morning, but let's do a little bit of trivia here. All right. So true or false, you need to be a specialist to treat BPD. So that's false, right? That's why we're here today, just to present to you that you don't need to be a specialist in DBT, for example. There aren't enough specialists anyway, right? So I think John Gunderson's idea was to come up with this approach to make treatment more accessible for people with BPD. And actually, a study by McMahon et al. Found that GPM is just as effective as like a good quality DBT. So individuals were highly trained in DBT, and GPM was just as effective in reducing symptoms and improving, I guess, other measures of life satisfaction. So true or false, clients with BPD rarely get better. I know I fell victim to this. Go ahead. It's false. So about 10% remit in 6 months, 25% in a year, and 45% in 2 years. And I think what we know about the course of the illness, symptoms do improve with age as well. So it's not the case that your clients aren't going to get better. True or false, BPD has a strong genetic component. So it actually does. This is surprising to me. It's a 55% heritability rate. So when you think of that, it's quite high. I think initially, as with a lot of disorders in psychology, we blamed inconsistent parenting. I think that was the dominant model, but now we know this isn't true. Of course, there is some interaction with, I guess, the symptoms of BPD and parenting, right? So you have somebody who's a little bit more sensitive and intense. Parents can either kind of withdraw or become angry and frustrated, and that interacts with the symptoms we'll talk about later. So BPD is fairly common. True or false? Actually true. I mean, when you see 2 to 3% relative to other psychological disorders, it's fairly common. But then you start seeing the presentations in different settings, right? So about 6% of individuals who present in primary care settings have BPD, 10% in outpatient mental health, and then a striking 20% in psychiatric inpatients. So clients with BPD actively resist treatment, true or false? So it's false. They can resist treatment, but often it's treatment not sensitive to their needs, right? It's not geared to how they present clinically. They're often willing participants in therapy, and that's been my experience. And then, yeah, the resistance, like I'm gonna get you to start viewing that as a symptom, and instead of them being intentionally difficult or resistant.
Okay, so I'm going to talk a little bit about diagnostic criteria. I'm not going to go through through all of them one by one. Everybody's seen DSM. The one way to kind of think about this is that, you know, the symptoms kind of fall into 4 clusters, right? Challenges in interpersonal relationships, right? Again, fairly commonly seen, one of the kind of crucial features of this disorder, emotion dysregulation symptoms, which is kind of like mood changing frequently and in intense, dramatic ways. Symptoms of impulsivity, behavioral disturbance, and cognitive symptoms, right? Such as, you know, kind of like when individuals with BPD get very stressed, they may become paranoid or even sort of like have these pseudo hallucinations, which is why for a while it was considered to be sort of like belonging in the realm of psychosis, right? Historically, borderline is sort of like a state between neurosis and psychosis, right? Now we know it's not quite true anymore. So there's a couple of ways to kind of like, I guess, work with these diagnostic criteria in practice. And one of them is to use a mnemonic that I picked from Daniel Carlett, which was one of the books that I kept from my first year in grad school, the psychiatric interview. Pretty good. So I despair, right? You need 5 or more of these symptoms to kind of diagnose borderline, which fall into identity disturbance, disordered unstable affect, and so on and so forth, right? Again, falling into these DSM, kind of like you have 9 symptoms, you need 5 of those, starting probably by early adulthood, but typically seeing before even puberty hits. So, and again, you know, this is kind of like a lot of information to take in. In practice, not all diagnostic criteria weigh the same. So John Gunderson, kind of, I'm citing him here, when you have somebody with severe abandonment fear and they also self-harm by cutting or what have you, it's 88% sensitive to the person having borderline personality disorder. When you add to that, I guess, history of high levels of interpersonal conflict, that combination is highly sensitive and specific, meaning that if you have all 3, it's probably borderline. And if you don't have a single one of those, it's probably not, and you got to look at something else, right? So this is a clinical diagnosis. At the end of the day, you need all the criteria to make it. But when you're talking to a person, maybe you see them for the first time, you can just kind of like start gathering some of that information and think, aha, okay, something's going on here. There's a number of disorders that really look like borderline in terms of just how they present, right? So bipolar 2 disorder is one of them. It's about as common as borderline, and they're highly comorbid, right? So in people with borderline, about 15% also have some form of bipolar diagnosis. And some researchers actually say it's a lot higher than that. So, you know, a lot of diagnostic overlap criteria. People with both disorders tend to be impulsive, do risky things, they can get anger, irritable, their affect is all over the place, a lot of unstable relationships for both. And depression is very, very common presentation in both kind of disorders. So to kind of help you distinguish between the two, again, even if you don't diagnose, it's helpful to be able to think through those things, right? In bipolar disorder, mood symptoms for hypomania tend to last days to weeks, right? And depressions, a few weeks to a few months, with periods of normal functioning in between. That's sort of like this classic presentation. In borderline, mood changes typically last hours to a day, and you would rarely, if ever, see a consistent elevated or irritable mood for over 48 hours. But you can't rely on symptom duration alone, right? The diagnostic dilemma is that hypomanias of less than 4 days are common. I think average duration of a hypomanic episode is only 2 days, which really starts to overlap. So you can't look at symptom duration as your only way to distinguish these two disorders. So here's, I guess, a couple of helpful tips. In borderline personality disorder, these insecure attachments and severe fear of abandonment is a hallmark. You can see sort of like attachment sort of disruption in bipolar, but typically they're normal prior to onset. And if there are disruptions, you can carefully screen for hypomanias or depressions. And if the only time there's sort of like disruptions in attachments that are during the episodes, well, maybe it's not borderline. Borderline PD tends to have early onset, and evident so disturbances are there prior to puberty and after. With bipolar, the onset's typically late teens or early 20s. For kind of like these affective storms, impulsivity, everything that we think about, kind of like how borderline presents. What tends to set those off in borderline are interpersonal events. We'll talk a lot about interpersonal hypersensitivity in slides to come. They can be interpersonal for bipolar disorder, but typically with bipolar, it's something like rhythm disruptions. Not getting a full night's sleep, starting a new job, that can set off an episode. And if there's negative family history of bipolar disorder, that kind of argues more for BPD if you're not sure which one it is. When you have both BPD and bipolar, BPD is considered to be the primary target in the GPM framework, because as borderline improves, you'd expect bipolar 2 to improve as well. And here's a couple of screening measures you can use to screen for bipolar disorder. Depression is highly comorbid, right? 50% in 50% of individuals, you also going to find them depressed at some point. So finding whether or not somebody is depressed is relatively straightforward, right? Episodes last at least a couple of weeks, but typically it's between 3 and something like 11 months. Depressions show a clear change in symptoms, not simply their presence. And symptoms also must last almost every day for duration of episode. There's a lot of changes to neurovegetative symptoms, right? So you're looking for the dip in person's functioning that lasts for realistically months, and that's a good way to kind of figure out if somebody's depressed or not. However, some depressions are sort of agitated. That's an old way to describe it, no longer used, but you have individuals who are depressed and they're highly keyed up, irritable, sort of like on the edge, or sort of a lot of agitation, right? That sort of might present, that might throw you off a little bit, because that's not maybe how we typically think of depression. And to complicate things even more, there's mixed depressions, or depressions with mixed features. When you have full-on depressive episodes, so you're low, tearful, suicidal, low appetite, don't sleep, but you also have 3 or more hypomanic or manic symptoms throughout the duration, such as you can have racing thoughts, impulsivity, risky things, lots of energy, decreased need for sleep, and irritability, agitation, insomnia are very common in mixed depression. So it can look every little bit as borderline and not actually be it, right? So at any rate, when you have both, borderline is primary target for the same reasons. Borderline improves, depression should improve as well. And here's a couple of screening measures, again, to kind of screen for depression or mixed depression. Post-traumatic stress disorder, again, very common, 30% overlap, sort of like comorbidity. You see all the same things: unstable affect, paranoia, dissociation, very intense anger, and unstable relationship, impulsivity. Again, kind of may look pretty much the same. So where the difference is to look for presence of criterion A trauma in PTSD, which is some kind of life-threatening event and sexual violence. And when you do find those things, you want to make sure that the onset of symptoms happens after the traumatic event. That's going to help you sort of distinguish the two. However, what makes it complicated is that not only is trauma fairly common, as we looked at that, clients may not disclose trauma history until much later into treatment. And that happened to me when I worked with a person for years. And I thought it's borderline until the person disclosed sort of like this recurrent childhood abuse and neglect. Which is kind of like where we're at, right? Trauma can happen very early in childhood, so it's very unclear clinically if it's PTSD, borderline, or maybe both. When you have complex PTSD, which is when these repeated kind of like early life traumatic events, you probably would want to treat that first so that GPM can be a viable treatment, and borderline second. When you have something along the lines of a more simple PTSD, such as a single event, right? Borderline would probably be your treatment target. You make sure the person's more stable before they can engage in some form of exposure treatment. And a good measure to screen for PTSD is the PCL Leg 5 measure freely available. All of the measures that I'm kind of citing here are, I think, public domain. And there's other personality disorders. I think it's fairly common when we run into people who have anger issues, or they're difficult, or they're maybe obnoxious. We think, oh, they got borderline. But there's a lot of other personality disorders. So narcissistic kind of being one of them. For one, it's highly comorbid with BPD. And narcissistic individuals may fly into narcissistic rage when they feel slighted, but they rarely show remorse afterwards, unlike individuals with borderline who very often feel quite bad about sort of like doing those things. And then there's obsessive compulsive personality disorder, probably most common personality disorder. And they can experience significant inappropriate range when they kind of lose a sense of control. May look every bit like borderline, and that's when you kind of might at least consider, okay, there's what 10, 12, something like that personality disorders in the DSM. Borderline doesn't need to be your kind of like default mode of thinking for angry individuals. And I don't know if, Shawn, you have anything else to say about that before we move on.
No, that's good.
All right. Right. So when you're not sure what's happening in front of you, you see somebody for the first time and they're a tornado, you can organize your kind of hierarchy of differential diagnosis according to the safety hierarchy that Dr. James Morrison suggests. First, consider things that are sort of most desirable to have, in the sense that they're either most urgent to treat, most likely to respond well to treatment, and have the best outcome. So any disorder due to substance use or medical illness would probably want to be top of your list of thinking what's happening with the person, right? You don't want to overlook that. Then you consider it to be recurrent depression or mania or hypomania, because again, you don't want to miss those things. They're relatively easily tackled. And then you move on to more middle ground, such as, well, is it PTSD? Is it borderline? Is it substance use disorder or something else? Because they take a little bit more time to kind of resolve. And finally, what belongs at the bottom of your pile for considering what's happening with the person is things that are hard to treat and have poor outcomes: schizophrenia, malingering, antisocial personality disorder, and more. And keep in mind, diagnosis is kind of ongoing, right? If treatment is done well for whatever you think it is, if it's depression and there's no improvement, doubt the diagnosis, right? You give somebody an antidepressant and they get worse, and that doesn't get better with a couple of weeks, well, maybe it's not depression, right? So, kind of keep that in mind, I guess. And over to you, Shawn.
So we'll just talk a little bit about how GPM conceptualizes BPD, which is a bit different from, I'm sure, what you're used to. So the hallmark feature of BPD, according to GPM, sorry, a lot of acronyms there, is interpersonal hypersensitivity, right? So these individuals are a bit more sensitive than your average individual. This is in contrast to DBT, which views the hallmark symptom as emotion dysregulation or difficulty regulating one's emotions. And I guess like Gunnarsson basically said, this interpersonal hypersensitivity is the most discriminating factor, right? So it best discriminates BPD from other disorders. So their view is that events in the personal sphere are the things that trigger relapse in people with, with borderline, right? So suicidal behavior, self-harm, anger, abandonment, fears. Usually it's something happening interpersonally that's triggering these behaviors or these emotions. So I'll just give you a client example here. I had, oddly enough, I had a client call me from the emergency department of a hospital, which is interesting. But if you think about it, this person, again, had BPD. They're very sensitive. I don't know if you've been to an emergency department lately, but they're not always the most warm, inviting places. So she was waiting for 5 hours, and then she was admitted to a bed, but then nobody really came around much. And she was having some anxiety because of some pre-existing kind of distress she'd experienced in an emergency department. So she was really feeling rejected, like they didn't care for her, didn't like her, right? You know, same client had a bit of a medical license suspension, and family members came to visit. The family members didn't always hang out together because they didn't get along. But she kind of assumed that they knew her license was suspended, and they went shopping and didn't invite her. So then, you know, I received a distressed email. You know, and then the other big thing is relationship breakups, right? So there's many relationship breakups, as Nikita talked about, and we'll talk about more. There's this tendency to try to seek, you know, that attachment with others romantically. So sorry, go back one. Nikita's trigger happy this morning. I'm just kidding. If a client's experiencing a decline in functioning, it should be to the point where you're asking yourself, okay, what's going on interpersonally that triggered this? And you want to get the client to start making these connections as well. So this is a bit of a model of different interpersonal emotional states that occurs in individuals with borderline. So you've got the held or attached state. You know, there can be depression, rejection sensitivity, idealizing others in relationships, or collaboration. You've got the threatened state, where individuals can become angry, self-punitive, manipulative, right? And they can devalue others. And then alone, where some dissociation can occur, some paranoia. Again, Nikita pointed to the, you know, borderline being between neuroses and psychoses. This is where you start seeing some of these symptoms. And then this kind of desperation, and this is when the impulsivity kicks in, right? So self-harm or suicidal behavior. So, you know, as clinicians, what can we do to promote, I guess, this held or attached state, right? So when the person's feeling alone, we want to become involved, right? Let them know that we're there for them. This can happen with hospitalization. So you'll see someone with borderline personality disorder, they'll be hospitalized, and then their symptoms will kind of dissipate. And some clinicians take that as a sign that the individual is being manipulative, but that's not really the case, right? They're feeling more attached. And then as far as the threatened piece, clinically, we want to focus on sorting out why they're angry, right? And it's important to note that we might trigger some of these angry reactions in these individuals, as it is a disorder of interpersonal relations, right? So there's 6 overall treatment principles. The first one is to be active, responsive to the client, and curious, and instead of reactive, right? We don't want to feed into the anger. We don't want to be defensive. We want to just take it slowly, figure out what's going on. Sometimes these clients need more structure, so you don't want to take a strictly humanistic approach where you're following the client. You want to challenge their passivity or their silences or even avoidance in session. And you always want to model that cautiousness and thoughtfulness. So let's think about that, right? Instead of reacting. So the second one would be a source of support via listening. Obviously, I hope you're doing that. Interest and selective validation. So you might hear some outlandish things, but you always want to find what's reasonable and sane in what the client's saying, because there's always something, right? So we have to do a little bit of work and maybe be thinking ahead of the client there, but yeah, definitely achievable. And obviously we keep harping on the interpersonal nature of the disorder. So clients are more stable when they have a predictable, supportive source of care. And again, I'm going to hit on this point again, is the modeling the sense of curiosity and figuring out, because when you do that, your client will hopefully start adapting that. So we have a short video here just illustrating a couple, these first 2 points or principles.
All right, I'm gonna need to stop and start sharing to get this going. So just give me a second here. Here it is.
Hopefully everyone's caffeine kicked in and you're still with us.
Let me know if the sound's not working.
Sorry to hear it.
Are you now? Well, I'm sorry to inconvenience you.
I'd like to hear more about what's going on.
You'd love to hear more about what's going on?
I would.
Now that's interesting. You are still in training, right? Did your supervisor tell you to say that to me?
You know, Sarah, I really do try and only say things that I mean. In this case, I really do mean that. I'd love to hear more about what's making you angry.
Now that's interesting. You only say things that you mean? You mean everything you say is the truth?
I hope so.
So nothing you ever say is accidental. Everything you say is what you're thinking? I knew it. You know what? If you had to live the way I lived, if you grew up the way I grew up, you wouldn't be so fucking perfect. Look at you with your perfect job, and your perfect office, and your perfect whimsical Monet painting on the wall. You know what? Maybe you should try to live the way I live for 5 minutes, and we'll see if that plastered little self-satisfied grin's still on your face.
Okay, Sarah, we're gonna have to take a step back here.
You know,
clearly,
borderline personality disorder is a really, really tricky condition, and I'm not too sure that you're cut out to treat it. You know what? I need a freaking real doctor who knows what the fuck is going on.
Okay, clearly, you're furious at me. And I have to admit that right now I have no idea why. I really care about what's making you this angry, but we can't get anywhere if I'm just fumbling around in the dark.
Guess.
No way, man. There's no way. I've clearly already put my foot in it once this session, and I'm not doing it again this fast.
Well, at the end of the last session, you told me that I was going to end up being nothing if I didn't get a job. I already feel like nothing. I already feel like less than nothing, and the one person that's supposed to be supportive of me just tells me that I'm nothing. Do you know how that would feel?
So last week I said that, and this week I said I always mean what I say. I'm really sorry. Clearly I'm not as perfect as you accuse me of being, since I obviously made a royal mess of that one. You know, if I could take it back and do it over again, I certainly wouldn't phrase it that way. It was really clumsy. It came across as mean, and it was only half true.
Half true?
Well, yeah, half true. I mean, I do not think you're nothing. I think you're very special. I think you have a lot of strengths. For one thing, you have a great sense of humor. But I really do think it's important for you to get a job.
Here we go again.
I phrased it in a stupid way, but I stand by the fact that I think it will be helpful.
Okay, going back to the slides.
Yeah, so you saw there that the therapist wasn't reactive, right? They modeled that curiosity and figuring out, and they took responsibility for their actions and realized that they could have been part of the event that triggered anger, right? So third principle is focus on life situations, relationships, and vocations rather than what happens in treatment. So as Nikita mentioned earlier, right, we want to promote people to have a life worth living. There's a tendency for those with BPD to become professional clients or patients, even though we do know the disorder remits. So we want to move away from that, right? By focusing on those real life situations. So get a job, right? This is I know it sounds silly, but it's not. It's an important tenet of GPM, is to promote people living, right? And so work gives people a sense of purpose. It gives them structure. It helps with their self-esteem. You know, we want to avoid encouraging clients to get these things from romantic relationships because of the interpersonal hypersensitivity. So they will seek these things through relationships. It's not saying they can't have romantic relationships later on, but you know, the way GPM builds it is like, well, you have to like yourself in order for others to like you. I know it sounds cliche, but you know, that's the focus. Let's improve your self-esteem by being involved in some social roles and work, and then maybe we can look at the romantic relationship piece of things.
And I'll add to this a little bit. Not so long ago, I had a client with borderline personality disorder who had issues with her boyfriend, and I was kind of like, well, do I leave? What do I do, right? And of course, as the clinician been there, you're sort of tasked with providing the answer for that, and you know, tread carefully, right? And you all know this. So one of the things I guess I did using these sort of GPM principles, and it really worked, is I kind of encouraged the client to wait and see and instead focus on employment, school, other friendships, right? Sort of like not saying yes or no, leave or not, because no matter where you go, you're going to fall short as a clinician, right? But to kind of say, okay, hang on a second. So, you know, you have this new work coming up. Are you excited about that, right? Why don't you put a little bit kind of like more interest and energy into that as opposed to this relationship that disturbs you so much? And I guess sometimes it works, right? Client was pretty receptive to that. And if they don't have anything like that, you're going to help them build it.
So you want the therapeutic relationship to be real and professional. So put on your Carl Rogers hat, I suppose. You want to be genuine, focus on the present, and use selective disclosure. So, you know, not necessarily about your life, but about your reactions and your feelings in session, right? So, oh yeah, that would piss me off too. Or, you know, you really gave me a scare there when you called and left a voicemail saying you're going to end it, and then you didn't pick up when I called you back, right? So yeah, you want the effort to be collaborative for obvious reasons. You also want to make sure that the client knows that you've got to count on them to manage their own distress, right? Instead of rescuing them, and then that reinforces that they're not able to do this on their own. So same client actually emailed me distressed. I didn't pick the email up until Monday because it was a weekend, and so I just emailed the client back. It's like, is everything okay? And she's like, yep, I figured it out. I met with my women's group a couple times over the weekend. We had dinner, and I was able to calm down. So you're all gonna have vanilla ice stuck in your head now. So 5, change is expected. So this is important, right? A lack of change is indicative of treatment failure. You don't want to necessarily add more sessions. I think Nikita will talk a little bit about that later, but.
Right. Well, I'm not sure we can mention this now, right? One of the things in which you can get trapped, and I certainly did not so long ago, right? Client becomes more distressed because of life stressors and such, right? You have more dysregulation, more affective storms, all that sort of stuff. And then you're tempted to add more sessions, sometimes twice weekly, right? Which GPM allows, certainly no more than 2 times a week, right? But then it's a bit of a problem because then effectively you're reinforcing unwittingly a person getting more of what they want by being more distressed. And it's important to kind of not let that happen, right? If you're not progressing, you're not changing, you have to address that, right? And you have to actively question treatment and say things like, I kind of have a sense that maybe I'm not helping you as much as I could, right? You don't let that slide forever and ever. Just add more sessions and hope for the best, because it's a recipe for a disaster, right?
So the client has to be responsible for change, right? They're the primary agent, and you have to hold them accountable for that. We don't want the treatment to primarily depend on the therapist's resume or their skill set. Obviously, you have to have skills and a bit of training, but you know, it's really up to the client to implement these things outside of session.
There we go. Just tried to click on thing. And just to kind of add to that, one of the things you could do is, well, why not, if you have the capacity or desire, why not add additional sessions? They don't have to be 1 hour sessions. They can be 15-minute sessions when the client does their homework. Hey, you know, we're seeing each other on Monday. You did your DBT homework and you read the skills, you applied them. You have your 15-minute bonus on Friday, which is a whole lot better to do than wait till they become more and more in a crisis, so that then you can give them that 15-minute check-in, right? I think, you know, again, this kind of like they have the responsibility to get better, and sometimes you can give them a little bit of extra incentive to do that.
Absolutely. So just we'll go a little bit more into what treatment might look like. So the first step is an unapologetic disclosure of the diagnosis. So what you can do for this is even take out the DSM, for those of you who, you know, are, I guess, regulated to do so. Take out the DSM, go over the criteria. I like to do it in a collaborative manner. I don't think GPM specifies that, but, you know, checking in with the client. Does this fit? What do you think? You can even say, you know, I'm not so sure this symptom fits with you. What do you think? Or an alternate approach is a more developmental approach, which we'll show you here. I think we just need to cue it up to 440 there, Nikita.
Yep. Just a second here. There we go. Let me know if the sound's off.
Emotional sensitivity, and you know, they just feel their feelings more intensely than most people, and they're more likely to react to their feelings, and they're probably calm that way. And then they may be a little more likely to attribute anger or rejection to people that take care of them, and they grow up feeling like it's unfair, like life is unfair, and they can't get their needs met. And then as they enter adulthood, they want to find an exclusive relationship with somebody that can help those needs feel met. But because that relationship is so intense and so important, any perceived chink in the armor of that relationship makes somebody feel angry or bad about themselves. One of those two. And if angry leads to doing things that upsets the other person and can destabilize the relationship, if bad can lead to suicide attempts, self-destruction, which can sometimes get other people's support, which then kind of reinforces the unrealistic idea that they're supposed to be this saving good thing, and it just keeps repeating.
Kind of like what I've just gone through.
Kind of like what you just gone through. Yeah.
Yeah, you described it to a T.
One second. Here we go.
All right. So yeah, I think a fear of clinicians is that the client's gonna, you know, become angry or, you know, reject this kind of presentation. But in my experience, and you know, in the GPM model, it's usually quite rare.
And I'm going to agree with Shawn here. I communicated this diagnosis multiple times, and more often than not, people either aren't surprised or they're relieved. I recently wrapped up work of maybe 2-3 years with one of my borderline clients who said that it was probably one of the most helpful things I've done is to give the diagnosis, because it kind of made sense their symptoms and what's been going on in their life all of a sudden made a whole lot of sense. And when we understand what's happening with us, we're a whole lot less scared and hopeless, right? And it's a diagnosis of hope, which is not how it's been seen for probably most of its existence, right?
Yeah, so obviously the first or the next phase would be alliance building. So you want to establish trust, roles, as we talked about earlier, and just the client goals. And one of those overarching goals is to get a life worth living. Obviously, you want to examine distress through that lens of interpersonal hypersensitivity. So building a narrative with the client using their autobiographical information. You know, how does the situation we're currently talking about relate to past experiences or, you know, time in between sessions? Have you noticed a pattern? You can use chain analyses for these. It doesn't have to be strict DBT chain analyses, but you just want to kind of elucidate the relationship patterns that are occurring.
Right. So in the GPM, they kind of provide helpful benchmarks you want to be hidden along the way. And if you're not there, you kind of, that's when you go back to questioning treatment. So by 1 month in, you probably want to see some distress being diminished in the client's active in treatment, and you like each other, right? You got alliance going. 2 to 3 months, self-injurious behaviors or this chronic suicidality should be decreasing as well. And if it's not, that's when you know you're in real trouble very early on, because it's one of the first symptoms that you'll see decreasing when things go fairly well. And that's definitely something to be addressed if it's not happening.
There's a fairly recent study by Kramer and colleagues that showed that, you know, by 10 sessions, you're seeing an improvement in interpersonal functioning and also a decrease in self-harm behavior and suicidal behavior.
And if that's not the case, you're in murky waters, and you definitely want to address that, right? You know, if the client remembers what they learned in the sessions and applies these sorts of things outside, you're on good path. And if you understand the client and you like them more and you're more empathetic towards them, that's also a good sign. 3 to 6 months, you want client to be somewhere doing something meaningful to them, or some kind of social role, whether it's school or work or what have you. You also want them this far into treatment to be able to link, oh, I got really upset. Well, you know, the day before, here's what happened. You know, somebody was rude to me, or I felt like, you know, I let somebody down and I think they're going to abandon me. That sort of stuff, right? Links to interpersonal hypersensitivity, right? Their moods aren't random. And if they understand that, that can be very therapeutic. Your moods aren't random. It's got to do with interpersonal stuff. And the client trusts you more. In terms of managing contact outside the sessions, that's a tricky one, right? Because in DBT, we probably all heard, oh, you got to be on phone 24/7. And I don't think there's anybody who wants to sign up for that, right? So from the get-go in GPM, you stress it's not feasible for you to be available during crisis to manage the client's safety. GPM encourages this call me in an emergency kind of concept, right? You offer this tentative availability depending on the clinical setting you work in. And it's used very sparingly. It's neither encouraged nor discouraged, right? If a client calls you in a crisis, you speak for 2 minutes and they feel better. Just from that, you really discuss that next session, kind of say, well, what's happening there? You know, you only heard my voice for 2 minutes and you felt so much better. And again, you link that to interpersonal hypersensitivity, but you also kind of say, well, that's not a great way to manage your safety or well-being, right? And likewise, if an individual calls you too much, right, you also want to discuss that during next session. And again, you link that to interpersonal hypersensitivity. What GPM kind of finds is that emails and texts work just as fine as phone calls, right? It provides this transitional object, almost like a symbolic link that clients feel like they're not alone. And so I think in practice, and maybe we're going to talk about this just a little bit more, what I do is from the get-go, I kind of say I won't be reachable for crisis, right? I work that in my consent form for all my clients, and I develop a safety plan, which we'll briefly go over in next few slides. And when clients do reach out to me, which happens a lot more rarely than you'd think, right? I've pretty much never had somebody call me on my cell phone, for example, even though my clients have it. And occasionally get a frantic email, right? And unless client says I'm suicidal, then you kind of go like, well, I'm really looking forward to seeing your next session to discuss this. If you're in a crisis, use your safety plan or go to emergency department. And kind of say, hey, we have a meeting coming up in a couple of days. I'm really looking forward to that. That gives them a little bit of that extra, I guess, hope, right? I know, Shawn, do you want to add anything to this?
No, that's pretty much it. I work the same way, so I don't say that I'm going to be available at all times, but I'll occasionally answer emails or phone calls when I can.
Yeah. So you don't need to be like an on-call 24/7 therapist for every crisis. And dismantling designs with DBT also found that doesn't really do anything in the first place, right? So in terms of managing safety, right? Suicide is a very concerning and realistic issue. And so when client brings up any sort of suicidal thinking, you express concern first, right? Oh, that sounds really serious. Let's talk about this. So you find precipitants. Typically interpersonal. Well, has there recently been something, a fight with a boyfriend? Maybe you had a phone call with your mom that didn't go well, to find what sparked it off. Then you conduct your suicide risk assessment and you create a safety plan. So, risk assessment, once you've done it thoroughly once, so past history of suicide attempts, hospitalizations, all that kind of stuff, it doesn't need to take very long time. You can assess for changes in suicidal thoughts, especially if they're chronic, right? If they haven't been around for a while and all of a sudden they appear, you probably want to go in a little bit more thoroughly, right? But it can be a fairly straightforward process. And so safety planning, we're going to give an example what that looks like next slide. Sometimes I wonder if it's becoming kind of like the new no suicide contract, a sort of thing that you go through as a clinician to cover your ass, but also kind of like almost like a meaningless ritual. I had a client who I was sort of like updating her. We were updating the safety plan, right? So they're saying, oh, things are getting a little bit worse for you. Let's take a look at that safety plan we created. My client pulls out a stack of safety plans she got from different professionals and hospitals and kind of goes like, and this looks like a bit like a comedy, and it's not, right? Okay, no, that's not it. No, that's not. Okay, here it is, right? And so it's kind of like, that becomes almost like a meaningless ritual, right? So, it's not the end all be all. It's just one helpful tool for you to help the client out. I've also had clients who weren't acutely suicidal say, well, I don't want to do a safety plan. If I want to kill myself, I will. And I say, yeah, I know that, right? There's nothing that I can actually do to prevent that from happening, right? Unless I'm exactly there and we both know it, right? And then you kind of roll with the punches. If the client's not immediately suicidal, there's no need to hammer down saying we have to do this plan. I mean, you could, but I guess use your good judgment, right? Creating a safety plan does not mean your client's not going to kill themselves, right? Let's not fool ourselves about that. And if you delay that a little bit and they maybe bring up the issue again, I think that can help build alliance and then are much more likely to participate. Shawn, you got any thoughts on that?
No, I think we're good to move along here.
So safety planning, very straightforward. You don't need a printed form with all the kind of like boxes and stuff. Just ask them, what are you willing to do to increase your safety? And you want them to be collaborative. And if the client participates readily, it's a very good sign. So the safety plan itself, well, note the early warning signs, such as, oh, you said when you feel panicky, you're getting a drink to cope, that kind of stuff. That's a sign you're going to be probably working your way through the plan. Immediate soothing strategies, cover people, well, who can you get a hold of? Write their names and phone numbers. Who are people you don't want to call in a crisis because you know that things get worse when you do, such as your mother, boyfriend, whatever. What about professionals that you can reach other than me because I'm not available 24/7? And community crisis line, good to talk, whatever other local services are available, and you have them write that down with phone numbers. Actually ask people to take a piece of paper and pen to do that and put in their wallet, right? And make environments safer. Put away your pills give them maybe to a roommate, what have you. And you want to make sure, right, that if a client becomes a little bit more suicidal, does that have to do with therapy, right? And again, kind of keeping track of progress, right? Discuss with supervisor or colleagues and clearly document what you did in the session. And I think you're in a good path.
Just go over this quickly. I'm mindful of the time here, but treatment in GPM is multimodal, so it can include individual treatment, which it does, is the mainstay. Groups, so DBT, skills group, that kind of thing. Medication management, and family inclusion or family-based interventions as well. So the benefits of multimodal treatment is there's a lower dropout rate, there's fewer suicidal thoughts and self-injurious behavior. It's less burden on the treaters. You don't have to be overly concerned with splitting in the GPM model because they build some things in to address splitting. And then research indicates there's better medication compliance if medication is indicated for that individual. So there's a few rules though. You want to establish clear roles, especially when it comes to managing crises. So this would be a primary treater. And you want a secondary treater to maybe manage the medication or the individual manages the medication to handle family calls. So that way the primary treater can focus on the individual and treatment. It's important, obviously, for clinicians to communicate with each other. I know that's not, that's easier said than done in some settings, but some settings lend themselves to that. You don't want to accept vilification of other team members. Examine the issue with the client, but don't protect your colleague, but also don't agree with the client. You want to encourage your client to speak with the clinician directly in service of building those healthy ways of relating to others. So just a brief note on group treatment. They're excellent. They're very cost effective. They can reduce shame, right? It's like, oh, there's someone else who has this disorder. I'm not the only one struggling with these things. And then they promote all the social aspects that are curative, right? So social skills, assertiveness, self-other awareness. These are all things you want to encourage in individuals with BPD. But groups alone aren't usually enough, right? You need some individual time.
Okay, and briefly on psychopharm for borderline. We know medication does not cure borderline personality disorder, even though it's kind of heavily genetic, all right? But it can be helpful. If you do any sort of psychopharm, if you're a family doctor, you know, you can stress that therapy remains primary intervention. So in GPM, you want to kind of temper high expectations for medication, and you don't prescribe proactively for borderline personality disorder, right? You want the client to probably ask for something first. If they have comorbid conditions like just bipolar, something else, yeah, sure, you know, prescribe per guidelines. And you kind of want to establish the not knowing stance on medication, as in you don't know if it's going to be helpful or not. It may be, and you'd want to track it together. So one important thing in psychopharm principles with BPD is you want to discuss with the client which specific symptoms they want medication to target. And then you get them to commit to actually tracking that so that you know it's working. You want to discuss all the side effects, withdrawal effects, and encourage clients to do research on their medication before they kind of get on it, right? Definitely avoid polypharmacy, using more than kind of like one medication at a time. And establish with the client from the get-go, if the medication's not helping and not working out, we'll taper you off first before we start a new one. Although you may cross taper if the client is in severe distress, right? And tapering off unhelpful medications may actually be more helpful than starting new ones. If client really wants medication, but you think it doesn't need it, under the GPM guidelines, try an SSRI to preserve that alliance, because they can offer some small benefits from impulsivity, mood instability, and anger, generally safe, and have a kind of like a narrow side effect profile compared to alternatives. But make sure you screen for bipolar disorder first, because SSRIs tend to make that a whole lot worse. You can also express uncertainty about benefits. Again, that not knowing stance. Well, hopefully it helps, but we got to track it together. And you're really got to kind of go into therapy or kind of like keep working on those interpersonal skills. If client does not want any medication, but you think they need it, well, you can be curious about past experiences, beliefs about medication, and gently encourage them. In terms of general preference, SSRI is more preferable than low-dose, short-term atypical antipsychotics, followed by mood stabilizers. If there's comorbid disorders, you just prescribe per guidelines. Finally, tricyclics don't use. SSRIs, again, kind of like mentioned earlier, they can be helpful, right? Primarily for major depression, which is so common. Again, make sure to screen for bipolar. Mood stabilizers can be helpful for affective instability, but mostly for anger and impulsivity. Again, some mood stabilizers are a lot safer to use, like lamotrigine. And you use them at normal doses. Low-dose antipsychotics can be helpful across the range of symptoms like impulsivity, anger, cognitive perceptual disturbances like that paranoia, but they can be sedating and cause weight gain. Borderline is also comorbid with eating disorders, so you want to kind of make sure you don't overlook that. Again, so like you start with the low dose and you go slow increasing it, and you encourage tapering and discontinuing antipsychotics after stability is achieved, right? Which is like 2-4 weeks. And anxiolytics like benzos, generally not recommended. You only use them intermittently to manage crisis, right? So that's kind of like psychopharm for BPD in a nutshell. And finally, hopefully we encourage you to take the course on the GPM training. We're not affiliated with it. Again, right? We don't get any proceeds or anything like that. But Harvard Medical School has this course that 8 hours self-paced that goes through all of this stuff we covered in a lot more detail. And it's only like $25.
Yeah, it's again, we want access out there for clients with access to treatment for clients with borderline personality disorder. It's cheap because there is a big grant given by a former client of the program, McLean Hospital. So that's why it's so cheap. $25 is a good investment. And the best part is you get a certificate that says Harvard on it, so you can tell your mom you went to Harvard.
Harvard Medical School.
That's right, Harvard Medical School. I'm sure she'll be happy.
Yeah, exactly. So, and that kind of concludes our presentation. I guess I'll stop sharing at about this point. Questions time, right?
Hi, we have a few questions that have come in, and a few more likely will come in, so please submit them by chat, but I'll get started. So one question, if their attachment issues make sense with their childhood history and abuse, neglect, and relationships, would that speak more to trauma? I was once told if the disturbances contextually add up based on relational experiences, then it would not be BPD.
I can give my 5 cents and maybe then Shawn, right? I don't think it's a good way to distinguish because, again, sort of like trauma is common in BPD. Trauma does not cause BPD, but it's common enough where you wouldn't be able to know from the get-go. And this is where you probably want to start looking at things like interpersonal hypersensitivity pieces, right? Like fear of abandonment, this very severe history of self-harm, and history of ups and downs throughout their life in all sorts of relationships. I think that would be a more reliable indicator if it's BPD or not.
Yeah, I don't think it has to be either or, right? It can be both. So I would, yeah, look, like examining the diagnostic criteria, you could still have relational trauma and issues that can result in BPD, but also PTSD.
Thank you. Curious as to the presenter's thoughts on the presentation of BPD symptoms and the racism and trauma experienced in the Black BIPOC community.
Like, sorry.
So it sounds like, do you have any thoughts on BPD symptoms as they relate to racism and trauma experienced by Black, Indigenous, color?
Yeah, I'm going to admit I don't know a lot of the research on that. Yeah, admittedly, I don't know very much.
Likewise, again, we're not specialists in BPD. We don't know everything there is to know about that. But when you think about kind of BPD being this diathesis, right, with high heritability rate, then presumably experiences like that can kind of like light the fire and spark the disorder, right? I think it's conceivable, but again, you'd probably want to consult research.
I think too is like you wanna be a good clinician. Look at the diagnostic criteria, as we talked about earlier. You know, and I'm just kind of guessing here. There might be a tendency for clinicians to attribute anger in Black individuals to BPD when it could just be kind of normal anger, right? Like anger is an appropriate emotion. So, I mean, you just, again, you want to be a good clinician. You want to know the criteria for BPD and diagnose responsibly.
Thank you. If someone is single and does very well while single with good mood and life functioning when alone, would you think this might be BPD?
I mean, perhaps, right? Again, if they, one of the goals of treatment is to get people to function really well in their life in the absence of this exclusive romantic relationship, right? So it could very well be a BPD in recovery, perhaps. I'm not sure, right? If that's what the question asked.
Sorry, I don't have anything to add to that.
Okay, perfect.
I apologize. I know.
Thanks. Someone said, thank you for everything you've shared with us today. Earlier in the presentation, it stated this treatment puts emphasis on psychoeducation. Are there some specific tools or resources you use for this?
Yeah, so the course is an awesome resource, and it doesn't feel like a course. Honestly, like you can kind of go at your own pace. It's very interesting. There's a lot more videos in our presentation. And also the book, I should have brought it with me, but Gunderson and Links. Links is a psychiatrist actually at Western University here, and they wrote a book. It's thin, it's very readable. That's another great resource. Nikita, what's the name of it? You know better than I do.
I think it's called Good Psychiatric Management. That's
okay,
that's
there we
the
go.
book. It's literally the book, yeah.
Thank you. And then we had some very specific questions around some symptoms and treatment options for people. So I guess if someone suspects that they may have borderline personality disorder, or that they know someone who does, what can you recommend in terms of reaching out and getting access to services?
Well, I mean, I guess connecting them to a source of support, I guess anywhere in the community, or even reaching out privately. But I would say best way to go about this is probably talk to your GP physician and say, hey, I think I may have borderline, right? Hopefully we raise enough awareness that there's more clinicians in the community willing to kind of look into that, so that, you know, wherever you go, you're going to find competent, good enough care, which is what this approach is all about. But if you kind of have some concerns, go talk to your GP. They're kind of like a gateway to everything else in the community normally, right? That's what I would say.
Thank you. You mentioned that dismantling designs of DBT have shown that the DBT component of having someone on call 24/7 may not be as necessary as it seems, which supports the GPM approach to emergencies. The questioner asked, do you happen to remember the reference? And is it tricky to neither encourage nor discourage emergency contacts? Because if the call is a positive experience, it would seem to encourage calling, at least from a behavioral perspective.
Go ahead, Shawn.
All right. I think you mentioned that reference, Nikita, so I'm just going to put that on you. But
okay, I'll look it up.
Yeah, it is a tricky thing to, I guess, encourage. I think you have to distinguish between, you know, that extreme distress where somebody might be suicidal, and, you know, perceived distress where maybe it is a stressful situation, but not a life or death, right? So absolutely, I'd always encourage calling others if you can, or using that safety contract if you think you might be in danger or you're having suicidal thoughts. But otherwise, yeah, I guess, what am I trying to say here? Always reach out in those emergency situations.
Not necessarily to the clinician though, right?
Yes, like within your safety plan. And I mean, Antonio is right here. It could encourage people to reach out and get that reinforcement from others. Do you have any?
Yeah, which is why you give them, hey, you read through that chapter of DBT book, you got 15-minute appointment with me extra on Friday. And then lo and behold, that reading and those skills get done. You can, again, the behavioral part of it is you can encourage them to use that kind of like proactively. If they, and again, you know, if you do that from the setup, like this is how the treatment is, I'm not going to be your crisis person, but we'll make sure that you have somebody. I haven't really ran into a lot of problems. They're going to push boundaries. You're going to get emails and maybe phone calls, right? And then you talk about it in the session, right?
Yeah, with respect to like reaching out to others if it's not an emergency, you know, that's something you could talk about in treatment, right? So like, oh, I called my friend and she said I'm bothering her and this isn't important, right? So that's the interpersonal aspect you'd want to explore in session.
Yeah. Or like, hey, if you reach out to somebody, you don't need to talk about feeling suicidal. If you're not like at the point where you need to reach further services, right? But do something together, go for a walk and talk about stuff that's not, that doesn't have to do with your disturbance right now. Sometimes that can be enough for a person to feel attached, held, and all of a sudden these symptoms go down. If that doesn't go, work up the hierarchy of your safety plan, reach out to somebody else and then to professional services, right?
Yeah, and the idea is to encourage the client to intervene with their safety plan before they get to that last level where they're feeling suicidal.
Yeah, exactly. I had the client not so long ago go to the hospital and stay for a couple of days, follow the safety plan, right? Like, good job, right? You've done all the right things in the right order. You're safe. Well done.
Thank you very much. I don't see any other questions in the chat. So if there are any more, I'll give us another second, but we really appreciate your talk today. I think the seminar has been very helpful for a lot of folks in the community. We will be sharing a recording of the session and some link to a survey. So please be sure to tell us how we did today. Any closing thoughts or remarks from either you, Nikita or Shawn?
Well, thanks for being here. Thanks for the thoughtful questions.
Yeah, likewise, appreciate it. And hopefully we're able to kind of like, we're not specialists in this and you don't need to be, and it doesn't need to be this thing you dread, right? You know, one of the things I'd want to avoid doing is people, oh, Nikita's the borderline guy, right? Shawn's the borderline, send everybody to them, right? We all can take 1 or 2 or 3 maybe, and that's gonna alleviate, it's going to give people good service and alleviate a lot of stress in the community, right? Thank you.
Thank you so much. So we will be having more of these seminars, Coffee with Colleagues with Jennifer White and Family Services Windsor-Essex. And so you watch your email for more updates on the next session. Thanks, everyone. Have a great day.
Thanks, Allison.